Hello, and welcome to the Things I Want My Daughters to Know podcast, the podcast redefining women's health one unfiltered conversation at a time. I'm your host, Jacqueline Rose, and every week we will sit down with leading women's health experts and real women to share their lived experiences, bust health myths, challenge outdated and uninformed narratives, and explore what's really possible for women. We'll explore the truth around women's health, from periods to fertility issues, menopause, hormones, and aging, and everything in between, while sharing practical, evidence informed strategies that you can use to feel more connected to your body, empowered in your choices, and confident at every stage of your life. This podcast is for every woman who felt confused, dismissed, or left out of her own health conversation. It is a space to celebrate women, break the silence, and open up an intergenerational conversation between mothers, daughters, sisters, aunts, and friends. Let's get started. Hello, everybody, and welcome back to another episode of the Things I Want My Daughters to Know podcast. And today I have a wonderful guest, and I'm so excited about the conversation. Everyone listening, hold on to your chairs because I know this is going to be a conversation that is going to ruffle some feathers. We may use some foul language, so please be sensitive if you have little ears listening. We are really going to go deep into the menopause and women's health conversation. Fiona Clark, I am so excited to have you join me. I am such a big fan of you and your work. Welcome to the podcast. Tell us a little bit about who you are, what you do, and we'll dive right in.
Oh, thank you so much for having me. Um, Good question who I am. I often ask that actually, because it's by background, I'm a journalist. So I spent a lot of time with the Australian Broadcasting Corporation. Obviously, you can tell from my accent, I'm Australian. And then I ended up coming to the UK a little while back through the sort of circuitous route. My background is in anatomy and physiology, but so I spent a lot of time in mainstream media, but also the last 20 years in medical publishing. Um, when I got here, I started a thing called Harley Street Emporium, which aimed to give evidence-based information to women on healthcare in general. It quickly morphed into talking about menopause. And so for about the last 7 years, all I've done is talk about menopause.
Yeah.
And in that period of time, sort of interviewing experts from around the world on various aspects of it, we'd always get to a point in the conversation where I'd say, what do we know about the evidence for this? And they'd say, well, we don't because the studies haven't been done. And after a
Yeah.
while, that just really started to annoy me. So about 18 months ago, I said to a couple of people who've been in the space for a long time, Vikram Tanalika, who's a obstetrician and
Yeah, who
gynecologist,
we love.
health expert, and Diane Danzebrink, who's one of the original menopause
Yes.
advocates. We need to start a charity. If nobody else is going to fund these studies, we need to do it ourselves. So the Menopause Research and Education Fund was born, and we got charity status literally probably about a year ago now, and have been trying to sort of educate people. We run courses for doctors and raise money to support research in all of those areas that are so massively under-researched. And
Yeah.
on top of that, you've kindly invited me on because I've just written a book about this because,
Yes.
as you and I know, having watched this landscape over the last, well, 7 to 10 years, it has changed a lot.
Yeah.
So I've documented those changes and what it means in terms of policy, economics, advocating for ourselves, commercialization, all of those sorts of things. So it's not your usual menopause book.
Yeah, so we're going to dive into that. I'm going to ask you about that, but I do just want to say about your menopause research and education funds. I've participated in some of your trainings, your CBT trainings, and you really are sharing as much of the information without all the emotion involved, because there is a lot of emotion involved when it comes to menopause conversations, menopause research, evidence, what's available, options, choices, what are the gold standard recommendations, etc. So I know we're going to dive into all of that, but I think a great place to start is your new book. Because, as you said, it is not your regular menopause book. Most menopause books on the shelves are talking about yes, HRT, no HRT, holistic approach, symptoms, how to navigate it. Your book is very, very different. And I'm really honored that you gave me, an advanced copy to have a look through. Explain to me why you decided to write your book, which is a very different approach and what you're trying to get at.
It's interesting, actually. We were out for dinner with my son the other night, and he said to me, "So, in 2 words, how would you explain your book?" And I
So I've written a whole book.
And then actually, I thought once I got home, health politics. That's really health is politics.
Ah,
Women's health is politics. So yes, it is looking at it from a very different angle. And the reason why I came to do this in the end is over that period of time that we've talked about. What started off as a sort of collegiate movement of women coming together and saying enough is enough. We've got to make a better system for ourselves, and we were all united and collegiate. Has really split.
yeah,
And I've watched this develop, and the title of the book is MenoWars, because that's really sort of what's happened. We've got this sort of rise of very popular medical influencers, and I know everybody hates that word. I hate that word too. I hate being called it, but that is what we call them these days, influencers. And they've got huge followings, and
yeah,
they're saying this, and the medical establishment has sort of sat back for the last few years, going, "Oh, we don't know how to deal with that. It's not our job. We're here to serve our members. We don't talk to the public." But then it kind of got to this point where they thought they're going off piste, and we do have to do something. So they've, in their own conferences and things, they've raised evidence-based medicine and that kind of stuff. But once they've started to hit social media,
yeah,
they've got really nasty responses, and it seems to be that sort of rift seems to be growing further. But
yeah,
while they've been waiting, then the commercialization space has grown.
yeah,
Of course, the women are being, targeted with M-ticked, pink-ticked products, and God only knows what else. We've got femtech throwing stuff at us saying, "Take this test, do that, buy this." We've got a lot of stuff going on, and with very little regulation. So they're the main reasons why I did it. So I'm looking at the a variety of things in the book,
yeah.
which we shall go into, I
Yeah,
guess.
no, and I think that's really important that people realize because we went from a situation 5 years ago, and you and I have been doing this longer than 5 years, so we've seen the trajectory. 5 years ago, where there was no conversation or the conversation was only negative, to today, where there is a massive conversation and it's all over the shop talking about all different things. But at the same time, it has become a bit siloed. And there's sort of this mainstream narrative that has been propagated. And anyone else with any difference of opinions, talking about choices, options, alternatives are like marginalized. And we're looking at a very one voice, even though it's multiple voices, but sort of one voice narrative that now that is really becoming mainstream. And that is sort of where a lot of the problems I think arise because a lot of doctors will talk about, what the evidence says. And I love it when they talk about evidence-based information because we know there is such a dearth of evidence. So, what evidence are you actually talking about that there is so much there that you think, it's enough to set, policy?
Mm.
And then the fact that there is this real ignorance of any other ways of navigating this stage of life. So, how do you see that playing out?
Oh gosh, it's a really difficult one, isn't it? Because I mean, as you say, there are 1,000,001 ways to go through menopause. We've got, some women will have absolutely no symptoms and they'll be happy and fine and they'll sail on through. Around a third will have moderate symptoms, around a third will have severe symptoms. But yet, I mean, menopause is almost, in fact, I would probably say it actually is equally as divisive as weight loss. Everybody's got an opinion on weight
Yeah.
loss jabs, abortion,
Yeah.
those literally falls into that. Any decision that a woman makes about what on earth they're going to do with their own body
Yeah.
is so judged. So we've got one group saying, "Oh, you can't possibly have hormone replacement therapy. It's unnatural. Menopause is something that all women will go through. It's a rite of passage. What's wrong with you, Snowdrop? Get over yourself. And
Yeah.
then we've got the other group sort of saying, no, my God, it's a deficiency. If you don't take any of this, you literally will end up crumbling in a wheelchair in a pile of your own incontinence, but not even actually even compass mentis enough to know that you're there. So you've got these two polar extremes when
Yeah.
the reality is there are a million and one ways we're going to go through this. And it really is up to each individual to make the choice between them, their health provider, on what is best for them. So that's really the message that I'm trying to get across in the
Yeah.
book, actually, in the end, is ignore the vast amount of hyperbole out there. Know your own body, know your own symptoms, know what the treatment options are, have an informed conversation and make a decision for yourself because
Yeah.
it is absolutely nobody else's business.
Yeah. So I agree with you 1,000%, and that is my approach also. But you brought in another actor there, and that is your healthcare professional. So, yes, you need to make an informed, educated choice. And the way that we do that is we go and ask the people who understand women's health. But that's often where the problems arise because our trusted healthcare professional often doesn't have the information and doesn't have the knowledge, and they themselves don't know what to tell us. Often, people like us who are in the menopause space and very well educated and read and understand that, 101 different range of options, the doctor, healthcare professional, gynecologist doesn't have that information. And I just want to, if I can, quote a statistic from your book that talks about members in the British Menopause Society and members in the American Menopause Society. And you bring a statistic in your book that says there are 54,000 registered GPs in the UK and 7,133 obstetricians and gynecologists. But as of January 2025, the BMS only had 2,500 members. And to be a member only means you need to pay your membership fee. It doesn't necessarily require you to have gone through any official training, done any courses, done any professional development. And in the US, according to the statistics you bring in your book, the situation is even worse because you say that the Menopause Society has 7,900 members as of 2024. But there are over 500,000 primary healthcare physicians, around 118,000 family care physicians, and 20,000 gynecologists. So we're talking about even those people that are registered in the menopause societies are a small fraction of the overall medical healthcare professionals. And even if they're registered, that doesn't mean that they are trained, educated, informed.
No, absolutely. And as we've seen from Diane Danzebrink a couple of years back, did a Freedom of Information survey of universities here in the UK and their medical schools and what they taught about
Yes.
menopause.
Yes.
Some had no idea if they even had it on the curriculum.
Yeah.
Some had, an optional 1 hour. I think the best was Edinburgh University at 10 hours. But
Yes.
basically, there was no basic education taught to medical students until it started last year, thanks to her campaigning.
Yeah.
Then we have the situation where, despite numerous calls in Australia and here for mandatory catch-up education to be done by
Yes.
GPs, the colleges have both said, well, no, we don't need to do that really. Our members know what they're talking about. They get exposure to it when they do their GP training rounds. The problem with that is then if they end up with somebody like my old GP here, who when I moved from Russia to here and I came in to get my HRT script renewed, he looked at me and said, well, what do you want to do that for? You're just postponing the inevitable. And so if somebody goes through training with somebody who has an attitude to that or believes that, I mean, I've heard people say that their doctor told them, I don't believe in HRT, it'll give you cancer, you're too old, you're too young, all of these sorts of things. If they're not educated and you're doing your training with them,
Yeah.
you're not emerging any the wiser. So
Yeah.
that's another flaw in the system that really does need to
Yeah.
be overcome. It's a battle.
Yeah, it's really, and again, I think we don't often understand the depths of the problems because there is such a massive menopause conversation, because menopause is all over social media, because you have your big name influencers that are talking all about it. And if they've got an MD, at the end of their name or a doctor in front of their name, you think, well, they know what they're talking about, so I'm going to listen to them and trust them.
Yeah.
And I'd like you to, because you did set up this amazing charity, the Menopause Research and Education Fund, tell us what the situation is around that evidence-based sort of phrase. What research do we know exists? Where are the flaws? Where are the missing gaps? And maybe that's sort of an entryway into this whole world of women's health and as your book talks about, that politicization or the politics of women's health in general.
Yeah, interesting one. I mean, you would expect, given that we're 51% of the population and that we do suffer more from chronic illnesses such as depression, autoimmune diseases, osteoporosis, you name it, we have it. We have an equal risk of having a heart attack by the time we're 65 as a man, all of those sorts of things. You would think that we would be equally studied. However, however, that is certainly not the
So
case.
silly, Fiona.
I know, I know. It is those sort of naive things where you sit there and you go, what? So basically, even in studies on those things where we are more likely to experience it, we're lucky if we make up 40% of the cohort. And if you're Black or Asian, basically you don't even exist.
Yeah,
So, which is just depressing.
yeah,
Most of the time it seems to be around about 30%. Women weren't even included in studies mandatorily
yeah.
until it was
1993.
yeah, 1993, that's
Yeah,
right. And even then, it just sort of started off. They didn't use the money to include women in the studies. They were using it to pay for to pay for women to run the studies, as opposed to actually studying women in the
in the
studies.
studies.
And now we have another challenge, I guess, in the US with the sort of gendered wokeism in science, which
Yeah,
is going to, take the focus off including women in studies at a time when we really need to be included.
yeah.
That said, when it comes to menopause itself, you would think again, as we are 51% of the population, 100% of us go through it, that there would be a multitude of studies on menopause, and you'd be wrong once again. In the UK itself, I mean, the number of times in the book I say, and you'd be wrong, astounding, because it's a lot of times I say it, and that's very disappointing.
Yeah.
The National Institute for Health and Care Research is the body. The government gives them money. They give the money out to people who do research.
That's nice.
Yes. No, no, no,
That's
it's not.
good.
It's the National Institute for Health and Care
Oh,
Research.
for health and care research, sorry.
NIHR, that does my dyslexia in this one. So basically, they've been running since about 1993, and they've had X number of billion funds given to them. Over that period of time, until I can't remember when I think it was January as well, I looked too. So from 1993 to around about January, they'd done around 8,800 studies that they'd given money to.
Mhm.
Out of those, just 33
Wow.
mentioned the word menopause, just mentioned it. And then
Wow.
look at the amount of money that was allocated to those 33 studies. It was about 0.3% of the overall funding.
Wow.
So we really need to change that. So one of the things that we've been pushing for at the Menopause Research and Education Fund is to get ring-fenced funding, not new money. I'm not asking for the UK government to put in any new money in a time when they don't have any money, but just to ring fence around 3% of that money
Yeah.
to menopause research, just so we can actually really get on top of the things that do really work for depression, that do really work for osteoporosis, that do really work for reducing risk of dementia or heart disease, that do really work for incontinence. Because we have a lot of people saying to us, well, just slather yourself in estrogen and you'll be fine. But up till now, a lot of the research is lacking. It's often conflicting, and we need better answers, and we deserve better answers,
Yeah.
frankly.
Yeah. And a lot of just an extra point about the research, a lot of menopause research is done in women who have undergone surgical menopause, who have had to, for medical reasons, have had ovaries or uteruses removed. A lot of the research is not done in women who have undergone natural, normal menopause. So again, that brings up a different, you know, data set because you're looking at women who have undergone menopause for specific medical purposes and not natural, natural menopause.
Yeah, I don't know actually. I don't know what the breakdown is, but I know, I mean, a lot of the studies, I mean, people think, well, I think the main area where it's lacking is actually in perimenopausal women. A lot of
Mm,
studies are done in postmenopausal women because
mm,
it's got that nice even base of not having all of those horrible, pesky, fluctuating hormones interfering with your data.
yeah,
But the difficulty then is we're applying information that we've got done on a group which have like me, got flatlined hormones.
yeah,
And we're sort of saying, well, we'll apply it to them, but we actually don't really know. So that's an area that is I think needs to be improved. There needs to be a
yeah,
lot more on perimenopausal women.
yeah,
Um, and then does need to be a lot more on people who've gone through, POI. I mean, we know that, they've got a higher risk of various things if they're not given hormone replacement,
yeah,
if they go through early through either surgical or chemical or POI. But there probably needs to be a lot more research on them as well, especially after the so-called average age of going through menopause
yeah,
around about 51, their long-term outcomes. Across the board,
yeah.
there needs to be more research.
So let me talk to you about aging, health span, how we understand this sort of transition from perimenopause to menopause to postmenopause, as you said, like the depth of lack of understanding of what postmenopausal women really go through. And in terms of that assumption that you're going to, if you don't have HRT, you're going to, have dementia, osteoporosis, heart attacks, all the wonderful things hit you. We know today that women are living in postmenopause for at least a good 40 years, if not more. So, how do you see this conversation sort of playing out, especially as it relates to a lot of the narrative that is being propagated today? Again, we're not saying HRT, we're anti or pro. I'm not anti HRT, as we've talked about. It's about making the right decision for you. But there is so much now today on social media that if you don't take HRT, you are intentionally putting yourself at risk for bones, brain, heart, ill health as you age. So,
Yeah.
how do you understand that aging health span conversation?
Well, I mean, it is a tragedy that we do spend 25% more time in ill health than men, and we really do need to work out why. But is estrogen always the answer? That's the question. I think Pauline Mackey has really hit it on the head with dementia and things like that. She's a fantastic researcher in Chicago who has dedicated the last 40 years of her career to looking at brains and stuff. She may not be a household name like other
Yes.
people are, but her research is phenomenal. And she was actually the one who actually first found those estrogen receptors in the brain. And she too, in the beginning, and I outlined this in the book actually, she too said basically, I was a true believer. I thought that throwing estrogen at these problems was the answer. But then all of these other studies came out, if we're talking about dementia here in particular, showing that actually it wasn't the case. And as she says basically, how many women go through menopause? 100%. How many women develop Alzheimer's? Around about 20%. How many men develop Alzheimer's? 19%.
Yeah.
What age do they develop it? Now, this is the interesting bit actually, because we seem to be thinking that there's an enormous gap between men and women when
Yes.
actually the gap is really, really close. But the age we are diagnosed with dementia is in our early 80s. That's when we start to have more cases of dementia than men in
Right.
our early 80s. So then the question is why? And she comes back to the point of identifying that vulnerable brain. So it's not
Mhm.
every woman that's going to develop Alzheimer's. We've got to look at the ones for whom it is a bigger risk.
Yeah.
And where she thinks things are going at the moment are people who've got untreated vasomotor symptoms because they make those little hyperintensities in the brain in a similar way as high blood pressure does or sleep apnea. And if you're a menopausal woman and you've got sleep apnea, which is massively underdiagnosed.
Yeah.
We often associate that with, the sort of big fat white truck driver who's sort of, snoring badly at night and
Yes.
making the windows rattle. But if you're a woman,
Yeah.
and you've got that, if your husband, basically, my point out of that is, if your husband, partner, or whoever the person is, or sleeps anywhere near you, your neighbors are telling you that you're waking them up at night because of your snoring,
Boring.
get it checked, because these are the sorts of things that have an effect on your brain and your heart health. So that's where she's going. She's going down that route of sort of identifying then that vulnerable person, basically saying, if you've got those untreated symptoms, get them looked
Yeah.
at, because they're the things that put you at greater risk later in life,
Yeah.
rather than just the dropping estrogen,
Yeah.
because we all have the dropping estrogen.
Yeah.
The other thing that she did say out of that, though, was that people who carry the gene and have a family history like me of early onset Alzheimer's, there is evidence to show that we might be benefiting from estrogen, but at the moment it doesn't necessarily show that the rest of the population does. So they're the sorts of things, those little nuances. It's not a
Yeah.
one size fits all approach. It is
Yeah.
really identifying the people who are at greater risk. And the same with osteoporosis. We all go through menopause. We don't all end up with osteoporosis. Yes, we
Yeah.
have a higher risk. And there's an amazing man in the US called Mike McClung, who has done some really good research. And he too is saying, let's look at the vulnerable women. We
Yeah.
know that around menopause, in the couple of years before and the couple of years after, the amount of bone density lost is significant. It can be up as high as 20%. So if you enter that period, like me, I've got a +2, so my bones are, throw rockets at me, baby. I'm still going to be standing. But if you're entering that with a -1 already,
Right.
then the chances are you'll be osteoporotic in your 60s. Me, it'll probably be the 80s. So
Yeah.
so let's identify the women then who are at higher risk coming into this, so we can make sure that they've got the right sort of information and the right sorts of treatments to make sure that their loss isn't the full
Yeah.
20%. They come out the other end still with good, strong
Yeah.
bones.
I think you're
So
making such an important point because we do know that every one thing we do know is every single woman is going to go through menopause, regardless of health history, pregnancies, fertility treatment, whatever you had going on. But as you've said, I think it's a really critical piece of information that people seem to ignore. Not 100% of women experience all these
Sorry,
aging
that is my
diseases.
dog. She will stop in a second when the cleaner goes. She's
That's
outside
fine.
vacuuming the corridor door carpet for the first time in
That's
days.
fine.
Stop.
So we don't have a one-to-one ratio of 100% of women are going through menopause, and we see 100% of women experiencing, these degenerative diseases. And I think that needs to be brought up more because, as you've correctly said, we need to look at risk, at what else is going on in your life, what other health experience have you had, and begin to see the relationship between the 100% of women who are going through menopause, and then why are some of them living healthy long postmenopausal lives and others are not, and then to sort of start talking about, as you've said, not just this blanket statement, it's all about the estrogen. What else is going on? I saw, I think it was a research paper, maybe from the UK Dementia Society or something recently, where they talked about all the factors that lead potentially to dementia. And there's a long, long list of factors. One of them is severe head trauma, but there is a long, long list of factors
Yeah,
that
there are
can lead
about
to
14
dementia.
risk factors at the
Yeah.
Lancet that.
And in previous years, I would, tear my hair out. And where's the hormonal piece? And why are you talking about women and their increased risk? And why aren't you talking about estrogen? And I think with time, I've realized, yes, hormones play a piece, but they're one of those factors. There are 14 other reasons why a man or a woman could develop dementia, Alzheimer's, cognitive impairment. And I think that there was a time when we were sort of shouting, at everyone saying, include menopause, think about the women, talk about the hormones. But maybe we also now need to come more to an even, more balanced approach and say, let's look at everything that is going on here in the woman's
Yeah.
health.
Or
What
if you
else is
are taking,
happening?
yeah, if you are taking the hormones, don't rely on them to be the sole factor that's going to save you. Because, as you say, I mean, exercise is really important. Diet is really important. These are the things on that list of things. Keeping social. If you're starting to lose your hearing, get a hearing aid, because keeping social is really important. Same with your eyesight. If that means that you're not leaving the house and not interacting, get your eyesight sorted. Not drinking too much. Definitely not smoking. That's a really bad thing for your brain. And these are things when I looked at mum and I was looking at her and I was thinking, you are overweight, you have never exercised in your entire life, basically.
Yeah.
You smoke like a chimney.
Mm.
We did eat well, and you probably drank too much alcohol. And literally, when she had a vasomotor symptom, she just melted. She turned bright purple and just literally melted. We were living in Queensland, so it was hot at the time. But nevertheless, she just was a pile of sweat and or a puddle of sweat even. But those lifestyle things make a
Yeah.
huge difference.
Yeah,
So
yeah. And I don't think we're talking enough about it. So I do want to ask you about sort of how you view maybe what the conversation should look like. What would you sort of be your like, menopause presentation for having a well-rounded, informed conversation to give women language that they can say, look, I'm hearing this, I'm seeing this, my doctor's saying this. I don't know. Like that, with all the noise comes way more confusion. And as we've said, many of our doctors, as much goodwill as there is, they don't have the information. So, what is it that you think that women do need to know that, women, the messaging that you do want to be hearing?
yeah, it's an interesting one, isn't it? I think in many ways, there's a book that I refer to a couple of times in the book, which is Anise Mukherjee's Complete Guide to the Menopause. And she has a toolkit. So HRT is part of that toolkit.
Yes.
And there are so many other things in there. If you've got stress and anxiety, then you're going to need to work on that. If you've got high blood pressure and whatever, then you're going to need to work on that. So there are multiple, I think she describes it as, open windows in a house where all the heating's going out. And, you can't shut all of them simultaneously. It's going to be a bit of an effort. You're going to have to get a lot of them, shut one by one, but eventually you should sort of start to feel all right. But not necessarily thinking, oh, well, HRT is going to solve all of my problems. I'm never going to have an ache or pain again, and I'll never have to worry about dementia or bone loss or anything, because those other sorts of things, the lifestyle and the CBT or whatever it is, medications for your blood pressure, think of it holistically, a much bigger, broader circle of stuff that you need to do to ensure your long-term health. That's how I'd like people to be thinking about it.
Yeah, which makes it more complicated because it's not a nice, cute soundbite on TikTok.
Yeah.
And it requires women to do a lot of work. It requires the regular woman on the street to
Mm.
really be much more proactive and much more engaged and much more informed herself about what's going on.
Yeah, it is very difficult, especially if you have a doctor who's not well informed. I mean, it's all very well to have your symptom tracker and your symptom app and to walk in there and go, look how much I'm suffering with all of these things.
Yeah,
But if they're sort of looking at you again, going, well, I don't get it and I'm not going to give you HRT, then you've got no further ahead. So
yeah,
we do need to, and this is towards the end of the book, I talk about advocacy, and there are a lot of things that we do need to advocate for in terms
yeah,
of um, policy and in terms of the patient. But in terms of the patient, I think we really do have to push much harder again for GPs to undertake some form of catch-up
yeah,
education. In Australia, when they said that they wouldn't fund or they wouldn't, push the RACGP to introduce mandatory training, at least they came back with a tiny little $1.5 million investment in incentivizing GPs to do catch-up education, which is better than a poke in the eye with a blunt stick. So even doing something like that might be good. So we
yeah,
need to advocate for that. The other side of things, then, if you're the patient and you have gone in with that symptom tracker and your GP is looking at you blankly, then ask to be referred to somebody else in the practice if there is someone who knows what they're talking about. If there is nobody, to a menopause clinic, which of course then you'll be waiting a very long period of time,
yeah,
or simply maybe change practices. Find a practice that actually does have a
yes,
menopause specialist in it or somebody who's done that, because the numbers are growing, so there
yeah,
are more and more people who have an interest in it.
yeah,
But yeah, it's not easy. We need to advocate for a lot.
yeah. You mentioned policy, and I know that you're very aware of what's going on in Australia. They're really moving quite nicely ahead with sort of governmental recognition and things like that in Australia. What do you see happening policy wise? And do you see it as a good thing when governments are starting to implement some type of recognition? I know in the UK now there's a bit of a double-edged sword conversation about menopause recognition in the workplace and, sort of its categorization and what that means for women. Sort of how do you see policy playing a role in women actually getting the support that they need?
Yeah, it's a really difficult one. And there is a section in the book where I talk about conflicts of interest, because while Australia is actually ploughing ahead, the Senate inquiry was pretty much literally brought about by a single pharmaceutical company, but nowhere was that made public. And that needs, I think, to, you really do need to know these sorts of things, even though it's got positive outcomes. There is a danger when you're not being very transparent that, next time this comes around, let's say, depending on which side of the abortion side of the
Yeah.
fence you sit, if there is a Senate inquiry that's brought about by a bunch of pro-life lobby groups, and the result is that there's restrictions in access to the morning after pill and changes to the abortion laws again, you might not be so happy about the outcome. So transparency and declaration of conflicts of interest is hugely important.
Yeah.
That said, they are, luckily this time, this is something that most of
It
us would,
worked out well for the women.
yeah, it sort of works out well. Here in the UK at the moment, there's just, it's become quite stagnant, I think. The workplace stuff is interesting. And I think Jennifer Weiswolf, she calls herself Weiswolf, um, raised an interesting point when we say, arguing about the word disability is,
Yes.
should it be under the Disabilities Act? And, whether or not it should be classified as a disability. Basically, she's saying we've learned an awful lot from the disabled community over the last couple of years. To be saying it's not, to be saying that this is a bad word to describe it is actually doing them an incredible disservice.
Yeah.
So getting hung up on the wording might not necessarily be the best sort of course to go down to. It's not, having a disability doesn't necessarily, it shouldn't necessarily be a negative. If
It shouldn't be a negative, but this is not my own opinion, this is opinion held by some, is that the minute that menopause, which is a natural, normal, biological stage of a woman's life, is getting the recognition it deserves, but under the Disability Act, how does that place menopause? Would you ever put pregnancy under the Disability Act? Where does, in terms of pregnancy rights for women, shouldn't menopause have equal standing as pregnancy does? And the fear is that the minute that you put menopause under disability, it then actually makes women feel more ashamed to talk about it because then it has a certain status that the disabled community absolutely deserve their rights and their status, but it's a sort of a double-edged sword to put menopause under that categorization.
Yeah, no, I think it comes down to whether or not we view disability as a negative thing, as
Right.
opposed to just something that makes it, more difficult to do your job at that particular time.
Right.
So I think it comes down to how you define the word disability and whether or not you think it does or doesn't have negative
Negative
connotations.
connotations.
Yeah.
I hear that.
So, and then you make the workplace changes around it. So, if you've
Yeah.
got somebody in a wheelchair, you're going to make sure they've got access, a ramp that lets them into the door and things
Yeah.
like that. So you would do a similar sort of thing to menopause. So that's sort of the way I think that Jennifer is looking at it from.
Mm.
Um, the I think the thing that's really interesting about this is that we have a lot of policies. We have a lot, as in like policies being sold to companies, a lot of people offering workplace support and workplace coaching and all of those kinds of things. But as Susan Davis in Australia says, and she too has been spending 40 or so years researching
Yeah.
menopause. We don't actually really know beyond vasomotor symptoms and changes to periods exactly what the menopause symptoms are, or if they're just part of midlife. And she's recently done a survey of around about 8,000 midlife women, looking at when these symptoms start. And a lot of them they've found start way before menopause or perimenopause.
Yeah.
is it really a menopause set of symptoms that we're having, or is it really
Mm,
a midlife set of symptoms due to, a whole bunch of lifestyle factors? And if that is the case, how then do we accommodate those? It's all very well to have
fascinating.
saying, everybody's got to have lighter uniforms and sit by a fan and have access to the loo. I can tell you now, I certainly would never have wanted to sit next to a fan or even been offered one. I was the only one in the office with the heater under the desk. Well, again, a one size doesn't fit all.
Right.
Um, but yes, is it then, do we reframe it to not actually have anything to do with menopause and say midlife women are going through hell for a variety of reasons? If they are, then these are the things that an employer, if they want to keep them, should consider, and not necessarily say that it's menopause, because a lot of those symptoms may have started a lot earlier and might not actually have anything to do with menopause.
Interesting. That's really interesting because it then gets into the conversation of health and women's health versus menopause and what is specifically menopause. And I guess for our audience, what I mean by that is related to hormonal fluctuations
Mhm.
of our reproductive hormones and what is just you're living a super stressed out life, sitting at your desk for 10 hours, eating a sandwich for lunch, and that's creating your symptoms.
Yeah, I mean, if you think about it, we do have the sandwich generation, sick and aging parents, having kids later means, I went through this, two sets of hormones in the house at the same
Yes.
time
Yeah.
was not pretty, not easy to get along with.
Yeah.
We've got a lot of stuff going on, plus still being expected to come home and run the house, do a job, pay the bills, all of these sorts of things. We've got a huge amount to juggle.
Yeah.
And
Yeah.
it does put a lot of pressure on people.
Yeah. Fascinating.
Yeah.
Wow, so many interesting topics and so many interesting things. I think the one last thing I want to talk to you about, because the podcast is not only a menopause podcast, and because your book really does talk about the politics of women's health, what else do you see going on in women's health in general, in terms of how women are represented, understood or misunderstood, how women's health issues, non-menopause women's health issues. So, women anywhere from the ages of 15 to 45, things that they're dealing with. What did you sort of bring up in your book, or what have you seen from, your years in the field of that really the fact that women are just not well understood as a population. And when it comes to their health issues, it's even worse.
God, that's a really huge question, isn't it?
Yes, in 2 minutes, just like your son said, in two
It is.
words.
The first thing that really sort of struck me, I think, is the two things: the continued misogyny, and the continued judgmental approach to everything, as you say, from the age of 15 on. The normalization of heavy and horrendous periods for people with endometriosis. Just because something is common doesn't mean
Yeah,
it's normal. So
yeah,
they're the sorts of things that we really need to change. And when people get to perimenopause and those periods just go insane, they've
yeah,
got a double whammy there.
yeah,
So yes, getting rid of that sort of rhetoric of basically, well, women are expected to go through pain, so put up with it. I think that needs to change. I did have another thing in my mind, and now it's just gone straight out. What was the other part of your question?
it was about how women are just very misunderstood, very misrepresented, maybe the medical gaslighting. You talked about misogyny and being misunderstood, I think.
Yeah, yep, I think that actually it's not the other thing that has struck me is the erosion of trust. I
Yes.
think sort of goes back to where we were sort of at the beginning. Both of these go back to where we were in the beginning, really. And that is when you've got a bunch of really popular people saying, your doctor doesn't know what they're talking about. We're the
Mm.
information. They've been withholding information from you. They're acting as gatekeepers. They're keeping you in the dark. And I might really in my mind, why on earth would a bunch of GPs who have 10 minutes to see a patient who are stressed and often come home in tears themselves, why on earth would they want to be keeping their patients in the dark about things that could help them? Because
Yeah,
if things could help them, they'd see them less and they'd have more time to spend
yeah,
with other people. So, I mean, the logic of that argument is just extraordinary. But what it does is it undermines that trust in the very people who are sticking to the evidence-based guidelines. And there's a very good reason to stick to evidence, because if you stick to evidence, you are less likely to do harm. It may take a long time to change things. And yes, the WHI was an enormous mistake against women that didn't really do a good job. But generally, guidelines are there and they're made by people who have women's best interests in heart. And most people who go through medicine, I think, pretty much are there to help people.
Yeah.
So this idea of sort of going that, we're the elite of brainy people who understood this study, while all of them over there who spent years studying and doing these studies have been hiding the real information from you that was buried in the fourth paragraph in the bottom, but not included in the abstract or the conclusion of the
Yes.
study,
Yes.
really just serves to undermine trust and faith in a symptom that was actually there to serve you. And in the end, you might be very thankful that they are there. If you listen to an influencer who says, I cured myself of cancer because I ate Brussels sprouts and chia seeds for 10 years, and then you suddenly end up with a stage 4 cancer, you're going to be really thankful that you've got that medical establishment over there. And you're going to be hoping that they pull out the big guns for you,
Yeah.
because the influencer isn't always right.
Yeah. 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 And we know that to be true in many situations. Fiona, I end my conversations with my guests with the question that this is a podcast that is called Things I Want My Daughters to Know. But I always ask my guests, what do you want your daughters to know? And if you don't have daughters of your own, your goddaughters, your nieces, that next generation of women, what's the one thing that you really think they need to be knowing, that they need to know, and that, that information that you would want to just share with them?
Interesting. At my son's wedding, a sort of woman in her sort of late 30s, early 40s came up to me and said, I watch your podcasts and things. So is there an upside to menopause? And so I sort of reeled off the things that you would normally sort of say, like, you don't care so much about what other people think, and your
Right.
periods are finished and you don't have to worry about getting pregnant, and no more mood swings. And well, some people have no more mood swings, and it's not me. Whatever, a whole bunch of sort of things like that. And she literally crossed her arms and looked at me and went, is that it? And I thought, well, I didn't sell this particularly well. But what I really want people to know is, you don't have to catastrophize about this. I mean, if you are one of the unfortunate ones that has that, those really severe symptoms, there is help out there for you. You have options. You are now coming into this with so much more information, with so much more access to
Yeah.
information. So, you're in a really well-placed position in comparison to what many of us went through. I mean, as you know from reading the book, I did anatomy and physiology. I've spent 20 years in medical menopause, and nobody mentioned to me that my vagina was going to shrink or my clitoris could possibly disappear. Nobody mentioned those minor facts to me. But this next generation will know, and they will be prepared. So don't catastrophize. You may be lucky and sail through, or if not, you've got the information you need at your fingertips.
And I thank you. And I definitely think that when there is that fear, that expected, well, I'm going to have, 35 symptoms, then that catastrophization leads to increased anxiety, increased stress. And guess what? You actually may get some of those symptoms because there has been that fear built into your expectations of what was going to happen. And yes, there is plenty to be done if you are informed, educated, and I really appreciate that, that catastrophizing piece of the conversation is something that we really need to remove
Yeah,
from, for us and for that next generation of women. So
yeah. Recognize what's going on, and then if it bothers you, get it sorted.
yeah. So, Fiona, where can people reach you? I know you've got your book, you've got your podcast, you've got the amazing professional development training programs that you run and the research. So, where's the best place that people can find you?
They can find me at hello. What is it? Hello at mref.uk. They can find me there. They can find me on Instagram at it's a very strange name, but it was a difficult one to do, either because it was going to sort of look like it was sounding like MR refund. So it's
Right.
MRE_fund.
Fun.
So yes, or just Google Menopause Research and Education Fund, and they can find me there.
Amazing. Thank you. Thank you for your amazing work that you do for really being the banner of a sane, nuanced, balanced menopause conversation. We really, really appreciate you joining me. Everyone, go follow Fiona. She really does amazing, amazing work. She's a lot on social media. And thank you all for listening to this episode. And please join me at another episode at the Things I Want My Daughters to Know podcast.